Evening all. Bit of bonus content for you. So about a few weeks ago, I recorded a special edition for like Physio Natters. We thought it'd be really interesting to bring you a conversation I had with my colleague Chris Hayes over at IPOPS. 2 days a week, some of you might know, 2 days a week I work still in the NHS down in Staffordshire, Lichfield, and work with an ESP there called Chris Hayes, who joined the team earlier this year, and he's an independent prescriber. So that's been an interesting insight. It's the first time I've worked alongside someone with that particular badge. And so I wanted to bring to life some of the chats that we have in clinic and give you a bit of an insight into what that means and hear from the man himself. So really pleased that Chris was able to spend his time just chatting through that with you. I know you'll find it interesting. It is really, really good stuff, and especially because a lot of people ask me that question. I always feel a bit underqualified to answer, sort of when you should extend your scope in that direction. It's not something I've braved yet, but it's certainly Chris gives an insight now as to what it meant to him and what it's brought to his practice. So hope you enjoy it, and I'll see you at the other side. I'm delighted to be here at work, here at IPOPS, with my friend and colleague Chris Hayes. A first apology to Chris for this being the second time of asking. Just before my wedding, while still struggling from the aftermath of my hangover from a stag do, I definitely missed understanding how much was on our memory card and managed to get about 15 minutes into a conversation, 20 minutes into a conversation with Chris and this very topic before realising it. So that's straight out of the gates an apology for that. Second time of asking. Now, it's not long after we'd just done a recording with Dave Baker about independent prescribing came up amongst a wider conversation about analgesia. But Chris is our independent prescriber within IPOPS, and I've worked with him now, and it's great in a way. The delay has only suited me in a sense that I've had more experience working alongside you, as well as experiencing what independent prescribing's got to offer. So I'm really excited to have this chat about the practicalities on the front line of what that means, what it's meant to you and your career, what it means to this service, and we'll have a back and forth about it.
No, great, Jack. Looking forward to it. Excited.
A bit long awaited. Now, first question is easy. Well, just introduce yourself to the listeners, if you would.
Absolutely, Jack. Thank you. My name's Chris Hayes. I've worked as a physio for 17, 18 plus years. I'm an independent prescriber. I've worked as an ESP for about 6, 7 years. Been prescribing for the last 18 months. So I've worked with Jack since February, and
you're still sane, just about.
Still sane.
Just tolerating me, and he sits next to me, the brave sod. Like, if you ever wondered how patient he was, like that tells you. So, what key insights has becoming an independent prescriber brought you?
That's a really, really good question, Jack, because I think it's got a number of layers to answer that question, but I'll try and keep it as succinct as possible. Generally, as an independent prescriber, it provides me with the autonomy to prescribe prescription-only medication to the patient, to the clients we see. It's brought on a whole wealth of lateral thinking in terms of the education program as an independent prescriber, learning more and more about the use of the BNF and understanding the role of prescribing in a musculoskeletal context. So yeah, it's been fantastic and lots of positive feedback from patients, from staff, and ultimately it's added to the remit as a extended scope physiotherapist. So it's been a real positive experience.
One of the things that I find interesting, reason I phrase the question like that, is because medics, they never have the moment where they're a professional that's qualified but can't prescribe, and so they are straight through. They're in amongst it from day dot in a sense. But you were a physiotherapist prior to being a prescribing physiotherapist. So what has that step sort of brought that you otherwise didn't have? And has anything surprised you, or has it been as you expected it to be?
I think the ability to gain as much patient mileage in the specialty that we work in, for ourselves it's musculoskeletal care, and understanding the role of a number of adjuncts to improving patients' experience of their physiotherapy input, being able to prescribe has only enhanced that. So if it was coming at it from a medical perspective, where you land on the shop floor with the ability to access a number of interventions, one being the ability to prescribe, it's very much coming at it from a slightly different angle as a clinician, and it's been really worthwhile.
No. It's one of the things that I've really found interesting when working with you, which has admittedly surprised me, is just how medication can become part of, well, it should always be interesting to our differential diagnosis, but it's only through insights via you that I've come to realise just how it can play a part with the way that it behaves around symptomology. So when considering differential diagnoses, do physios underestimate the potential for drug side effects to be a contributor or even a key causal link to their symptoms in MSK practice?
I'll try and break that question down in a number of parts, but in terms of symptom onset, I feel that as a clinician, identifying the onset of patient symptoms, does that correlate with a change in something? That's something, if it is a new medication, it's correlating whether has that got a contributory role or has it got a strong causal role. So that's one point. From an onset of pain perspective, we all are very aware of the research in terms of the experience of being in pain and some of the causal factors. And I think that from the aspect of using medication as an adjunct to care, understanding the role it may have in the side effects, particularly of well-known medication causing arthralgia, myalgia, and other systemic symptoms which could masquerade as the patient's presenting complaint. I think what's really key is, as a physiotherapy clinician, we have an awareness that this is out there as a potential associated, contributing or causal factor. Mm-hmm. So yeah, it's important to have that lateral knowledge, and I think as a clinician, the more we understand of the role of the different medications that patients are taking, the better informed we can be in the overall patient care.
The more finger-pointy bit of my question was, do physios underestimate that? Because I totally, wholeheartedly agree. I mean, I'm pretty sure I'd have agreed with that before working with you, but also now experiencing independent prescribing. I nearly said first-hand, but second-hand, but closely second-hand.
Yeah.
Now, do you therefore think that is your experience that physios, and you can reflect on what you were before you did the
Absolutely.
course, like do you think you underplayed it, or did you always sort of get it?
No, I think I by far I've never got it in terms of having the reasoning processes to sort of appreciate, is this particular patient symptom purely a medication cause, or is it a mechanical, biomechanical, movement-related disorder? And I think in picking the assessment to pieces, do physiotherapists, go back to your question, Jack, do physiotherapists really hone in on the fact that is this a medication side effect cause to their presentation? I would say it's in the background but not in the fore. So from an assessment perspective, I think we need to be very aware that it's there as an involved component to the assessment. So I do think physios generally, in my experience, including myself, do underestimate that has a particular role, and certain medications are more prone to those symptoms associated with joint pain.
And some of the obviously conditions that they're taking them for should start to ring bells. I think I recognised fairly quickly into being, when I first started to extend my scope in various roles, I realised how the past medical history, the drug history, not always, but too often it was a tick box exercise for me. And I felt immediately guilty when I recognised just how complacent that had been. And so I imagine it's only an extension of that you come to realise that not only should it not be a tick box exercise, but it's actually a really important room that you need to walk into and access in certain circumstances, more than others. Sometimes you get away with it being a tick box exercise, but really it should be thorough, and especially with our complex sort of comorbidity issues that we've got in society right now, it's only good practice to be aware of it. Is that fair enough?
Absolutely, and I think the subjective examination holds a very strong assessment. Part of the assessment, it's well known that a very detailed, thorough subjective examination guides your reasoning processes and your objective testing. So as a clinician, as a physiotherapy, as an ESP, I think the considering of the patient's past medical history along with their repeat and current medication, including dosages, has a very strong component, has a very strong part to play in our reasoning process in terms of our outcome following the tests and the musculoskeletal impression that we come up with following our assessment. So one that we've spoke of a number of times in clinic is alendronic acid, and that's well known for causing generalised arthralgia, and I think there's a number of other alternative medications that can be tried, and I think if you're considering that this is a medication side effect cause, then it's certainly worth trying an alternative in that instance.
And I want to just try and hover on a few examples, alendronic acid being one of them. Statin's a more classic one. I mean, people probably hearing my questions and things, and even when you started to say a common one would be, I almost feel like statin would be on the tip of their tongue if it was a pop quiz, because that is obviously a very common, even more common medication than alendronic acid, but also one that is still got a known sort of issue that we have with generalised arthralgia or just generalised aching. And are there any, I mean, we can hover on those too if we need to, but are there any other classics in which it's just make sure you keep an eye out for that correlation?
Statins particularly, as we've mentioned, the key in terms of what's really important to understand, and this became clear to me doing the prescribing course, is that an individual's sensitivity to a drug varies. So in every instance, it's always important to consider, is the medication going to have a different effect on each person? So it's very difficult to say this is a medication that's known to cause these symptoms, and any adverse drug reaction, albeit minor sometimes, is reported via the yellow card system. So what's really important is for me personally, when I prescribe a drug for, in our remit, it's pain. So it's knowing the person's response and whether that is an expected response and a mild common side effect, and then the person's informed of that and they can become empowered by knowing that this is expected and not a shock, or is it an unwanted, quite a rare, bizarre side effect, and then which can occur, which if a person's never taken that drug before. So on individual merit really on different drugs.
And so really it's about making sure we identify correlations with any changes, and then probably raising that with a prescriber, someone with the medical knowledge to intervene, pick up a BNF, trying to work out whether it's coincidental or whether it's relevant. And
absolutely, and I, for one, before becoming a prescriber, I looked at the BNF every now and then. If I saw a drug on a patient's drug history that I'd never seen before, I'd have a look at it. But since becoming an independent prescriber, I've got to know the BNF really well and understanding the different sections and how helpful it is. So it's a very useful tool.
It's a clever book, isn't it? I never realised necessarily just how well the format is so relevant, and getting to know it is a really useful.
It's a real friend.
Yeah.
It's a real clinical friend in terms of drug interactions, which we can talk about today, and it really helps you identify, is this person appropriate or not for the drug you want to prescribe.
No, for sure. Now, what's the best course of action to take for a physio who suspects that med use is worth, well, for one, let's start where we were, which is that what should they do if they suspect that there is a relevant interaction, and then so that you can flow straight to it, how should they best go about it if they think something is worth tinkering with?
So I think if it's part of your clinical reasoning, as following a subjective examination, that's in your thought process. Is this a symptom indicative from a drug that the person's taking, or is it a mechanical cause? Then the assessment in terms of reproduction of patient symptoms. If, for example, somebody has a shoulder pain that's presenting like an impingement, for example, and the physical examination's quiet and there's no pain, there's no stiffness, no weakness, and you check the neck and there's nothing to think, well, this is not presenting like a mechanical source and cause, then you would think, well, is this more of a symptom secondary to the drug that they're taking? Often drug side effects tend to be systemic as well, so they present more bilateral type symptoms as opposed to a unilateral. So that's another sort of clinical reasoning tool in terms of the likelihood of it being this, or the probability of it being that.
Bit of a lookout.
Yeah.
Well, one thing I just want to hover on there, though, could a drug reaction, drug interaction, exacerbate existing symptoms and therefore not necessarily be bilateral? So is that a thing in which it could just sort of evoke or increase the sensitivity of that individual, and
Absolutely.
therefore it wouldn't necessarily present as bilateral because they only came in with unilateral knee pain, for example?
Absolutely. So for example, a person might describe to you that since they started taking a statin a year ago, they've noticed a general ache and discomfort in their legs, and then they develop a localized knee source of pain from a new activity, or taken up jogging or something, and GP's told them they've got a Baker's cyst, and they're wondering what that is and what's going on. So you might have a new sort of localized flare of an arthritic or an arthrogenic knee pain on the back of a generalized ache from a symptom side effect from a drug. So you would, as a clinician, work out what you treat. You might want to ask the GP to alter their statin to another one, or you might want to, together with the patient, treat the local new symptom. So it's all about that discussion and reasoning, and together with the patient, you come up with your treatment plan. But out of professional courtesy, personally, I would inform if someone was going to suggest, or is this a symptom side effect from a drug? If it was a drug which I hadn't prescribed, I would inform the prescriber out of professional courtesy.
I think it's I bet you've encountered this because I have as well. Because you just rung a bell with me about the generalised ache can sometimes inspire the change in activity. Sometimes
Absolutely.
people can then think, oh well, I'm getting old. Associate it as being a generalised mechanical reminder that they should do more. They start to do more, develop a mechanical problem off the back of this, which actually was a drug issue in the first instance, and that's sometimes like, what if not a thorough subjective assessment with this knowledge? I would nearly said extra knowledge. It should be fundamental, foundational knowledge that we're just bearing in mind. If we didn't unpick that, then who will? If not us, then who? It really is important.
Absolutely, and I think it's also that, particularly with minor symptoms of, particularly of minor musculoskeletal aches and pains, a lot of us put it down to age-related changes or not doing enough activity. Whereas, in actual fact, if it's a direct correlation with the start of a new tablet, then it's sort of informing the person, well, there's no need to put up with this. Let's ask the prescriber, which is often a nurse practitioner or a GP, can we try an alternative?
And suddenly they're drinking from the fountain of youth. They thought it was that they were wandering down to being a life of difficulty with joint pain.
It's all about
turn a corner.
Absolutely identifying sources of the symptoms, and I think as a clinician, as an extended scope physio, that's our bread and butter really. We're trying to facilitate patients' independence through identifying causal elements of their care.
Absolutely. Now, I think it's useful for us to walk the listeners through what it looks like, smells like, breathes like practically. What does the pros and cons of having a leader in medical management, or medicines management, in MSK services. So what if we can try and use examples if we need to, but what does it mean for you to be the independent prescriber amongst our service, and how does it sort of operate well or badly even? We can talk about pros and cons.
Well, I feel quite privileged to be given that title, really, Jack. I just see myself as another ESP muddling my way through a day, really, in terms of trying to do what we do. However, what I find useful, particularly with physio clinicians approaching me with the question, can this patient have some gabapentin or naproxen, amitriptyline, diazepam? Are there that they're deemed appropriate for that person at that time? The key thing for me as an independent prescriber is that the work up to prescribing that medication, the therapist has identified key succinct things during their examination that tell me that it's safe, providing all that information is safe to prescribe that. So the key things really is that I need to know what medications the person's taking and the dosage. So that's really important because, for example, simvastatin at 20 milligram, for example, is safe to take with amitriptyline, but simvastatin at a higher dose at 40 milligram interacts with the amitriptyline. So if it was just the person's taking simvastatin, they've got sciatic, neurogenic leg symptoms, I thought amitriptyline might be helpful for this person at this time. Or however, not on that dose of simvastatin, it's not a recommended plan of action. So I need to know the dosage that the drugs are, and their sort of general health really. What's really important is that anything we take into our system has to be metabolized. We need to know what the liver's up to, the patient's kidney function. So if we've got somebody with multiple comorbidities, there's, have they had their GFR checked? Have they had liver function tests? These might be objective markers that need to be checked before adding in a new tablet. So the patient's past medical history and a really succinct drug history, including dosages, is really important.
Before I forget, I think when it comes to elevating your title, I think it's everyone's got their own particular skill set, and so people might come to me particularly for puns and smart ass comments, whereas they might come to you for prescriptions, and I think everyone's got to have their own talent set. Now, what I would say,
I can tell a few jokes.
Oh, well, don't get me wrong, of course, but you've got much more versatile than me. I'm just smart ass comments only. With the workup, then, would you say that there is a certain someone with some comorbidities, I'm being really vague here, but on purpose, and we're looking at intervening, shall we say, or looking at trying to adjust medication. Is there a certain time frame in which you want them to have had a blood test within that you've got access to, or is that too prescriptive of me to suggest trying to put a number on that?
It's a really good question. I think in terms of how recent has a test been done to rule something in or out as it's deemed appropriate, I find that a very difficult question to answer. I think if a patient's symptoms have been static since their previous test, then that's one tick for being a reassuring outcome. But I think if anything's been over sort of 6 weeks, I'd be wanting to repeat that. So particularly if they've got established comorbidities and have had recurrent questionable blood markers, you'd be more suspicious. So, for example, if someone's a type 2 diabetic, has chronic kidney disease that's well known to the medics, and they have had a GFR of sort of below 60, which has fluctuated. That's telling me that their sort of renal function, potentially, if I'm prescribing a new tablet that's cleared predominantly by the kidney, I'm going to be quite careful and cautious with the prescribing. So you might lower the dosage. So the thing that we were taught on the course was start low and go slow. So you might start at a very low dose and titrate slowly up, or you may not want to titrate up.
Yeah. So it's very. I mean, that's the thing. My question was probably trying to overgeneralise. It's going to be specific to the anecdote of the patient and the particulars of their individual case. I've a question where I suppose just it sounds a bit selfish in a sense, but I'm just intrigued as to using us as an example. I've the privilege of being able to sit next to you and literally pick your brain when we've got a minute. But if I was to use that as an example, though, the access I have to your knowledge secondhand, what is the ceiling to what I'll be able to understand and achieve without doing the course? So I'm sort of wondering, not because I'm trying to put it off necessarily, but I'm just thinking, is it something that people can? I can tell that you think we should learn it, we should understand it, we should get to know and probably have conversations with those that are independent prescribers. But there will be a bit in which that will only get you so far, and you've got to take the plunge. So using the example of you and I, how much do you think that even if I was to irritate you every day and pick your brain every time we were working with each other, what percentage of that skill set will I be able to achieve in terms of reasoning and understanding, and when do you just need to take the plunge?
I think as a course, the content, it's a little bit like being an undergraduate physiotherapist. You do your course, you qualify, and you're safe to practice. As for all the sort of other aspects of assessing, treating, and patient management you gain over time with colleagues, with courses, skills that you develop on the job. As an independent prescriber, I found that the content of the course helps you to become safe to write a prescription and to identify, is this person appropriate to have this tablet. So the bulk of the course, there's quite a lot of pharmacology, looking at drug interaction, special care risk groups, because you do the course and you're qualified to prescribe for children as well. So it's really understanding that there's a whole array of medical knowledge that is brought into the course, which is very, very interesting. So as to whether somebody who doesn't do an independent prescribing course has the sort of ability to recognise when a patient is appropriate for a medication, I think we all do. We all know when someone has a symptom and you think, well, I think this type of medication will be most helpful, and now I need to work out, can this person receive it? Traditionally, we'd send the person in primary care back to their GP, back to their nurse practitioner with a letter to say, would you please prescribe this on this basis? And then 9 times out of 10 that occurs, and within our service we've got the autonomy where we can remove that from the patient's pathway. We have a seamless service between patient assessment and the receiving of a medication. So I think the course offers an extreme benefit and an important role to being ready to write a prescription.
And essential to take that responsibility,
yeah.
And put that onto your own autonomy, which is always really interesting to see our licence increase in that regard. So it's really good to see, especially having spoken to you as being, I'm sure one of the first to really be going through that, so to have had the experience you've had and wholly positive. So really, I mean, the great answer you've given there is yes, you encourage. It sounds like you encourage people to take the plunge and really, you advise that it's been a positive experience for you in your career.
Absolutely, I think it, like a lot of people doing a role which offers great autonomy, offers also taking on board more responsibility, and like as yourself, Jack, when we all started doing soft tissue and intra-articular joint injections, it's sort of knocking up that stress level as part of your patient management, you're intervening with a medical intervention where there's potentially serious side effects, and it's a stressful intervention, really. So remember when I wrote my first prescription, hand was shaking a little bit, and I think it might have only been naproxen or something, and there's always this sort of background fear that you're providing somebody with something that's very dangerous, potentially if taken wrongly.
The what if that always
Absolutely.
looms over us when we're doing anything new. But thank you, and thank others that are braving it and being the canaries in the coal mine, although it hopefully are safe for you to do so. And I know it's been a great pleasure to work with you so far. To wrap up, do the listeners, is there anywhere that they can reach you? I'm sure they can reach you through us if they have any specific questions, but particularly I'm interested, are you going to brave it onto social media? Are you dabbling? Do you keep an eye on Twitter at all?
It's quite embarrassing, Jack, because I am on Twitter, but I can't remember my...
Well, I'll shoehorn it in afterwards then. I'll have a look and we'll park that at the end of this. But so you are on there, and you maybe you can be baited into some answers via that. Then I'll drop it on there. That's not a problem. But I'm sure you'd be happy to answer any questions that they might have come via us.
Happy to, definitely.
Yeah.
I really I love physiotherapy. I love patient interaction. I love the whole being part of somebody's story in terms of helping them move on in terms of what they want to do. I think independent prescribing has helped me as a clinician become much more autonomous. And that, on a last point, Jack, not having the restrictions of a PGD, which is also quite useful as a patient management strategy. So offering other dosages that aren't not restricted by a patient group directive. So that's been useful.
The seamlessness is the word that sort of rings a bell to me, and I see that every day we're working here, is that the fact that we're able now to offer that completeness, that thorough care that we now know is certainly constantly cropping up in the evidence, that we want to make sure that we're exhausting conservative care, and to do that in one shop is a smart move, disrupting the patient's life less so that they can spend some more time doing what we ask them to do in their homework.
And I think on the back of that, Jack, being in an integrated service like we are here in IPOPS really facilitates swapping of reasoning across a desk, sharing ideas, being available to inject and prescribe with the physios in all one room. So we're obviously in cubicles, but the interaction really facilitates a prescribing role.
Oh, that's fantastic. And anything else you want to add before we?
I'm going to be hopefully doing some research of the role. So watch this space.
Brilliant. Yeah.
That'll be something to look at in terms of the patient satisfaction and the role in general, how it's working, and is it providing us with the expected results we'd hope.
Excited to see the numbers behind these noises, and we'll definitely share that far and wide. Thank you so much for your time. It's an absolute pleasure to not just work with you, but for you to spend your time after hours talking about this, and we'll
it's been a pleasure, Jack. No, I've really enjoyed it. Thank you.
It's always nice to bring you some extra goodies, and that really was from the shop floor as well. I think that's most translatable to most people's practice, and I think that especially in MSK practice we find ourselves bumping our head against encounters where medication would be smart to adjust and tinker with, and sometimes access is a problem, especially in a climate in which GP appointments are hard to come by. And so hopefully Chris has given you a clue as to, well, hopefully it's inspired you more than anything. I think people should pursue that option. Granted, I feel a hypocrite saying that, because it's something that I'm not on that course at the moment and stuff, and so people often would think, oh, it's all well and good me advocating it, but it's certainly something I need to pull my finger out on at some point. But I hope it's inspired you. Please do get in touch with Chris at the end there. He forgot his Twitter handle, partly because I think it's the least catchy Twitter handle I've ever heard, which is Chris27870150. So again, at Christo7870150. Now, I will do my best to encourage Chris to get a bit of a catchy, change that to a catchier handle. But until then, catch him on there, or via me, or via any of our sort of Physio Matters emails and stuff if you've already got them, and comment on this video. So I hope you enjoyed it. I'm sure you did. And definitely any independent prescribing questions or queries, then get in touch with Chris, because he is a font of knowledge in that direction. So thanks, guys, and I'll speak to you soon.